54 participants. This is the SWOG MU-NCORP PI meeting. And I'm joined here with Ray and Bernard and Kate, and we wanted to use this as an opportunity to hear from all of the sites about how COVID has affected your site, your practice, your finances, your concerns about doing research, opportunities, barriers. We need to understand from you what it's been like, what things have worked, what factors from the what different strategies from the NCI, from SWOG have helped maintain your research agendas, and what things you're still struggling with. Because the more we learn from you, the more we can try to creatively come up with solutions. Ray, I don't know if you want to take it from here. You might be on mute.
Yes. Yeah, thanks, Dawn. And hello, everyone. Good afternoon, good evening, probably not good morning, wherever you are. Welcome to the SWOG MU-NCORP PI meeting. And as Dawn said, we really want to turn the mic over to you guys. But right before we do that, we have Bernard Parker and Kate Castro on the panel with us. And we would like to give them each about 5 minutes to kind of tell us what NCORP is thinking in this time of COVID. Ladies first, Kate, would you mind starting?
Thank you, Ray, and good afternoon, everyone. It's great to be here in our virtual Chicago, as I will call it, and really appreciate the opportunity always to connect with everyone, and looking forward to hearing the open dialogue this afternoon. I think from the NCI perspective, I want to start by saying thank you to everyone. We know this has been an incredible year for you at your sites. And every site, we have heard, every region and every state has gone through different things at different times, dealing with the pandemic and all of the other issues that are going on in our country. And so we really appreciate all the incredibly hard work that people have put in to the commitment to the patients and to doing our studies. Ray asked me to kind of touch on sort of what's new at NCI and the NCORP side in cancer care delivery, and then what's ongoing. And I think what we have seen is something new, and we've gotten a lot of feedback from all of you on since the pandemic started, is the adjustment of doing a lot of our cancer care delivery protocols remotely. And many of those protocols were quite amenable to doing remote work. And so consenting patients remotely, which the central IRB put into place very quickly after the pandemic started, and also looking at opportunities and working with the research bases to look at how some of the interventions or some of the tasks that were being done on the protocols could be done remotely or by telehealth if that was something that was an option and would still continue with the good fidelity of the study. And we received a lot of positive feedback for that. And people really said that a lot of the CCDR studies were able to be done remotely when staff was working off-site or having different staggered schedules going into the workplaces. So I'd love to hear more about that this afternoon too, to hear how things might be changing or some feedback on that. And I know that there are protocols that we have, such as the Wake Forest study, the AHA study that has made some adjustments. Rochester has also got some studies that have made some adjustments to allow for more remote work. And I know that SWOG has a protocol that's coming forward, and they've already been thinking about that as they've been developing that protocol. So it's very, very good, positive, just a quick change and turning on a dime, but you all did it beautifully, and we're really happy to see that happen. We are pleased to say that we have 2 cancer care delivery research protocols that are in different phases of review at NCI. We have one that's at the central IRB right now, and another one, which is the SWOG study, which I know you'll hear about more in the cancer care delivery session tomorrow, but a financial navigation study that is under review as well at NCI. So 2 protocols moving right along, and we also have a concept that was recently approved by the Children's Oncology Group. And so really getting the momentum going for new studies down the pike. We've had a lot of good maturity for our current portfolio. And we hope everyone can join us for the second part of the NCORP annual meeting on Tuesday, October 6th, at which time Veena Shankaran from SWOG will give the presentation of her results from her study, her financial hardship study. And we'll also hear from Dr. John Tilbert for the Alliance Prostate Decision Aid study. So pleased to see that studies are completing and accrual is completing. The TRACER study, which had almost 4,000 patients participating in that, close to accrual last spring, which was another huge hurdle and really, really a positive experience for everybody who participated on that. What's ongoing? We're continuing, we just rolled out a new grant cycle in August. Everyone received their new notice of grant award, and the work goes on. And again, we've made some adjustments for COVID, but we hope that we're really continuing with that foundation that is the same. And looking forward to hearing from everyone this afternoon as to what we can do differently, what we could do to support you, and just how things are going at your sites. So with that, I'll turn it to my colleague, Bernard.
Okay, so thank you so much, Kate, for greasing the skids there for me. And I too would like to commend everyone, all of you, and the work that you have done and continue to do, particularly in spite of the COVID pandemic and the significant impact it's had on your ability to do the cancer prevention and control type studies. I understand that, of course, that the treatment studies, the NCTN type studies were able to proceed, albeit they struggled also. But we're still, I understand we're still at the tail end in terms of trying to recuperate from the COVID. We're still dealing with COVID, but in terms of accrual to the cancer prevention and control type studies, we're sort of beginning to pick things up again, and that's very encouraging. So I just want to commend all of you for the work that you're doing, particularly in this pretty interesting time, and concerns about exposure to this virus that can kill. So just wanted to let you know that since our last meeting, which was probably about 6 months ago, I believe, before COVID, and Ray had led this session of the workshop, there were concerns that were raised about the paucity or the lack of primary care providers and other non-oncology specialists to help implement some of the prevention and control type studies. So because of the excellent work that Ray did with the last meeting, we over in NCI had established a big workshop. Well, let's just say not a big workshop, but a workshop that was actually held about 4 days ago that focused on partnerships between primary care, between oncology researchers with primary care as well as with non-oncologists. And when I say primary care, that would mean physicians, nurse practitioners, and physician assistants, as well as non-oncologists of various backgrounds, whether they're in medical, such as dermatology, or these or gastroenterology, as well as surgical, such as urology, that since they are prominent with prostate cancer, early prostate cancer. Also, other types of non-oncology specialists, including non-physician specialists, such as nutrition and such as epidemiologists. In fact, you all already are aware that you have a study that has to deal with bladder cancer, radical cystectomy, and the testing of a nutritional drink. That's S1600. And so this is a study that, so among the various types of studies that are in the pipeline for the SWOG, from the SWOG research base, we decided to look into how we can help to augment patient enrollment through this workshop. And what we discovered is that, of course, we need to have significant input from the primary care providers, which you all have already known. So, so basically, I think I'll stop here, but just to say again that I commend everyone for all of the efforts that you have done and continue to do. And I will return the mic back to Ray.
Thank you, Bernard. I just want to let everyone know that the chat room is open. Please feel free to give us feedback, questions, comments. Also, we would like to hand the microphone over to anybody who wants to speak. We will do everything we can to accommodate as many people as possible. Don't see anything coming through the chat box yet. But we really want to give people a chance to share their lived experience in this time of COVID. We know that although we've all suffered, that suffering has not necessarily been uniform. We also know that the adaptations we've had to make at our different institutions may well be different in certain ways. One of the goals is to learn from each other. But, you know, if people just want to gripe, primal scream, you know, on the chat line, that's okay too. Just don't do it verbally. So while we're waiting to see if anybody raises their hand, let's see. Oh, it looks like
Ray, Ray, we have a question. Yes, we have a question from Augusto Ochoa. Augusto, you are unmuted and you're able to ask your question.
Oh, thank you. Thank you, Ray and Bernard. And I think this is a very, this has been a trying time for all of us, especially for the minority underserved MU-NCORPs, because we deal with a very vulnerable population. But I do agree with what Kate said at the beginning. I think all of the efforts to facilitate remote accrual of patients or remote management of clinical trials is important. I know we're all trying with different platforms and different modalities, and it would be great if we could somehow come together and start identifying which are the more robust platforms that could facilitate this process. Because I do think that those of us who have tried to work with community oncologists, with primary care physicians, and with physicians in rural areas are more adept to testing these opportunities. And I think these would be great clinical trials and great studies that could test, really put the test on these platforms to see how we can remotely accrue patients onto these trials. But I think this has opened, COVID-19 has opened the opportunity. It has removed a tremendous amount of barriers. It has facilitated a lot of the regulatory issues that used to exist before. And I think we've realized that, yes, we can do it, but I think we're all working with different platforms, and I think we should somehow come together through the NCI effort and through SWOG and organizations like this to say, look, these are the most robust platforms. Let's test 2 or 3 that we can really identify and work collaboratively to develop well-established SOPs, well-established and tested ways of doing this, so that we can invite our colleagues from primary care, from community oncologists to participate. They are eager to do it. The patients who live in rural areas and away from the major centers don't want to come to the major centers, especially not during COVID. And it doesn't seem like COVID is going to go away anytime very soon. So I think we really need to use this opportunity to expand our capabilities. And I love this discussion, and I hope we all participate in this. Thank you.
Thanks, Augusto. I think that's a very well taken point. And while we're waiting for people to pipe in, maybe I see Water is on the line. I would like to see if Water or somebody from NCI has a response to what Augusto just said.
Yes, yeah, thank you so much. That's from Dr. Choa, right? But, so yeah, I greatly appreciate it, Dr. Choa. I'm curious from you and from others that are presently involved, even though there is that silver lining that was mentioned, that's been repeatedly mentioned with regards to COVID and how it's provided opportunities for for remote activities such as remote accrual and even remote informed consent and remote treatment in some cases, or rather investigational treatment. Wanted to know, what are the challenges that you all find though with this new approach that you are dealing with? What are some of the obstacles or impediments that you're finding that would that you otherwise would perhaps took for granted back before the COVID era?
Those are very important questions, and I think we all find different barriers depending on where we are. But I think one of the things that is very important is that no matter what type of platform you use, you require some significant bandwidth to make these things work. The patients don't necessarily want to just communicate over email or messages. They actually want to see somebody on the other side, whether it's a nurse or nurse practitioner or a physician. And so that requires significant bandwidth. And if you start going, first of all, to underserved communities that have significant limitations in those communication devices, or if you go to the rural areas, this is one of the limitations we have. And so in some of the discussions we have had among different investigators and different groups, is the possibility of maybe bringing into the discussion some of the major companies that manage communications within our country to see if they would be willing to give some special pricing for efforts like this that have to do with healthcare. Can they provide special pricing or special technologies that would facilitate the process? Now, remember, we all talk about telemedicine, but telemedicine is very restrictive in the sense that you require specific locations with specific hardware, and therefore that limits the access to patients. But telehealth devices, where there's multiple platforms that can be used, not just in telemedicine locations, but also in the patient's own mobile devices, greatly facilitate that. And I do think that, again, one of the challenges I was mentioning at the beginning is there's multiple platforms out there. Which one is the best, which one we should use, is still something that's up in the air. And I do think that maybe coming together to discuss these platforms, to even invite the companies that lead this efforts to say, look, these are the things we need. These are the elements that we need to facilitate this tool for our physicians and our patients, would greatly help. And so I think that kind of discussion needs to be promoted through SWOG, through the NCI, and through the MU-NCORP in particular. I think would really help.
Can I just ask a clarification? You bring up really excellent points, and thank you for doing it. Are you specifically referring to platforms for like video consultations, or specific platforms for consenting, or companies that are going out and drawing bloods for patients in the community? Like, there are a lot of different aspects to it. And I just wonder what people have used in general.
Yeah, good question, Dawn. I think it's mostly video platforms, both communications with the patients and the physicians, as well as for consenting. We have worked around some of the issues of laboratory tests and things like that by having the local physician facilitate that process either through their office or through a site close by that will collect the samples and will mail them to the appropriate laboratories. But I think it's primarily making sure that we have platforms that are that meet the HIPAA regulations so that we can exchange information with the patient, so that we can talk under appropriately privileged conditions with the patients and exchange, obviously, the necessary documentation for consenting. We do that. The consenting process is done the way we're testing it now, and I must say that we're testing ourselves one approach. So I can't tell you that we have a lot of experience, but we have some. Has been directly by having the consenting process done with community physicians, and that has worked relatively well. But after that, it really allows us to communicate with the patients, and it brings a lot of assurances to the patient that they can continue in close communication with the treatment team. I don't know if that answers your questions, but it gives you a flavor of what we're trying to do.
Okay, it looks like we have another question from Alan Liss. Alan, you're going to be unmuted.
Okay, super. I'm here. Can you hear me? Here's my question. I wonder whether or not the pandemic might have opened for us a new category of CCDR research in which we test whether any of the adaptations that were made during the pandemic that were designed to be temporary adaptations should be continued, and whether or not there's anything that we would lose by continuing them. What I mean to say is, if we are permitted to have local providers do study-related exams under the supervision of investigators, with the oversight of investigators, and if we're permitted to send investigational oral agents directly to patients as opposed to carting them to them, if these kinds of adaptations can be done without losing anything in terms of measuring efficacy endpoints and toxicity endpoints, that's something we should know. And it would probably lower costs. It would expand access to patients. It streamlines processes for patients and for sites. On the other hand, if we are losing something in terms of measurement of efficacy and toxicity endpoints, that's something we very much need to know for study authors. Is this a category of CCDR research that might be open to us now that would be very valuable?
So, I mean, I can at least comment that we have a rich database that a lot of the sites have collected in, at least for study participants. We know, we're collecting how these things are being done and how the consenting was done, and there'll be ways of looking at some of these issues retrospectively. In terms of the general care of patients during COVID, we'll probably need a broader kind of database to look at that. I'm not really sure. I think it depends on the question in terms of what you can answer retrospectively, and hopefully we'll have the data or the data linkages where we can answer some of those really key important questions versus what stimulates a new question that we can try to answer in terms of, the delivery of care that we're giving.
Am I still unmuted?
Yeah.
I could see, Dawn, how the SWOG Audit Committee, for example, may be able to help us with the retrospective analysis of whether or not study analysis has been complicated. But I could also see a value for establishing some prospective studies of these sorts of questions.
Well, I can tell you we certainly welcome any ideas that anybody has for both prospective and retrospective studies.
Super. Thank you.
Yeah,
Alan, Alan, this is Kate. I just wanted to add in there that there are a couple of studies that I mentioned that we're just getting rolling here, some protocols that are just getting started, recently activated, who have made amendments in so that they could do as much as possible remotely. So those will be studies where we'll actually see, will there be a possibility to roll this out remotely? And there will be some patients on those studies that are getting the remote and others are not. And so there may be an opportunity there. And I agree with Dawn. I would love ideas for how you would consider protocols for moving forward.
I know from the advocate's viewpoint, many of these accommodations were viewed very positively. So I think we need to take them seriously for the long haul.
And, Don, I'll just throw in that there will also be opportunities for natural experiment studies, irrespective of what happens. So if for whatever reason, policy decides not to continue some of these things, that will itself create some opportunity for some rigor to see what the impacts of implementing and de-implementing might be. So all kinds of different ways one could go with this. I think I'm looking at the chat box, and there are a few people who are asking if they can jump in. Please feel free. This is an open mic session. Dr. Onitilo.
Yeah, thank you. So I just want to mention, say a few things about our experience also. Wisconsin NCORP, WINCORP. The first thing that was very helpful was that NCI allowed people to keep their funding, especially if they are doing COVID-related activities, because many organizations followed a lot of staff, and without the NCI allowing us to do that, it would have been very difficult if the supplement or the subsidy coming from our institution goes away because everybody was losing money initially and nobody knows what was going on. So that was very helpful. We implemented telehealth, of course, and that has been allowing us to maintain enrollment. So we're able to do teleconsenting, email patients, they mail signed consent back. We are able to mail medication now based on what the studies allowed. And now we can submit data online and we are doing virtual auditing. These have all been very useful. The only thing I think, as COVID continues to hamper things that we do is that we may want to look at some studies and relax some of the testing table requirements that initially would have been violations. Like you are not doing the CT scan within 30 days and you did it 32 days, or lab need to be done every week, and because of COVID and patients can't come in, we may need to look into some of the things and make studies more pragmatic and less cookbook regimen during this pandemic. Thank you.
Thank you, Dr. Onitilo. I think those are well taken points. I think lots of compromise is being made. So the usual push and pull between study rigor and having pragmatic rules that make it feasible to do the work is definitely something. And there have been accommodations made, as everybody knows. I see one or two names with question marks beside them. The chat room tells me that means somebody wants to ask a question, but nobody's stepping forward. So I don't know if this is just an inadvertent click that somebody made, or.
I think we're going to let everybody sort of open their own, maybe their own microphone, so that if you have a question, it's not so complicated to ask it. So we really want to hear from you.
This is Kathy Yost. I just wanted to raise an issue that we're running into. Now that COVID has subsided a little, we're trying to get back more towards normal in terms of work schedules and how we're doing things, and trying to bring more of our staff back into the office. And we're finding several staff, and I suspect this may increase, but several staff now saying they want to work from home permanently. Is anybody else seeing that? From my perspective, it's kind of the last thing I want to do. I've had kind of enough of this, but that's what we're hearing from staff now.
You are not alone. We've seen that too.
Yeah, we're seeing that as well. And I wonder how, and maybe people have insights in terms of what kind of problems this has brought up. I mean, there are a lot of advantages, but we've run into, I can say, some communication issues when lots of people are working remotely. I don't know if other people have experienced that as well.
We've had, as far as regulatory issues, that's gone very, very well. But, nursing is to a large extent a hands-on endeavor, and seeing the patients and meeting them at the clinic is extremely important. It's very hard to just have nurses stay home and try to do everything through Zoom meetings.
Yeah, I actually had a data manager who resigned because we didn't move fast enough to working from home for her. She opted and quit, a member of my research team. But it's also been kind of difficult in some of the things. So for me, I think the worst has been the new employees that joined our research teams right before the COVID pandemic hit. Getting them properly oriented, integrated into the team has just proven to be a nightmare.
So there are, I think it's an hybrid that works. So for the nursing and those that need to do face-to-face evaluations in some studies, there is no way around it. But like the last speaker spoke, regulatory and some coordinator activities can be done remotely. But the way to keep your staff, what we did was to talk to them individual. We do it individuals by individual, and if somebody need to come in once a week or twice a week to make sure that some paperwork and filing are done, we allow them to do what they can do remotely and then come to the office. And they've liked that, and we are able to keep some of our vital staff that way. But you have to work through your HR, because some positions are on site and some are remote by HR. So you may still have to keep that person as on site, and that's why they need to come in a few days a week. But you have to work through your HR for that.
This is Augusto Ochoa again. I think yes, there's no question that remote process, enrollment of patients and screening of clinics presents some challenges, but at the same time, I do think that there's two things that that our team and our nursing team has done extremely well. Number one, they meet remotely every week, and so they maintain the spirit and the enthusiasm of all of the people who are working. They review all their cases, and they go through their screening process. So I do think that not everything works as well remotely, but the screening of the clinics can work remotely without any difficulty. And if they identify a candidate that is likely to be a good candidate for enrollment, they actually do go to the clinic and start the process. So So I think that, yes, we cannot, not everything works exactly like we'd like to do it, but I think you can improvise and make it work for you. Obviously, this depends on your own clinic. But I think more importantly, you have to maintain the enthusiasm and the team spirit. And I think that happens when you're remotely, when you're so distant at this stage. You have to maintain those meetings, even though they're by Zoom, to discuss what's going on in the clinic, to discuss how the screenings are happening. And that's how our team has maintained the spirit in this whole process. We all had decreases in the numbers of enrollments, no question about it. But they rapidly came back because we maintained the team engaged and didn't let it simply dissipate.
Good. So those are very well taken points, very helpful. I think part of what we want is to hear similar nuggets like that, ways that we can learn from each other's experience. Anybody who has anything to share is welcome to get on the line.
Very sorry to be grump, but I wanted to raise a concern that I don't have all of the information, but my understanding is that increasingly large percentage of trials are going to require the detailed delegation of task log. And this is another situation where more and more is required and there's no compilation or accounting for the time, similar to issues that I raised before. But a number of institutions are very concerned about it, but I guess nobody has spoken up. So something maybe Bernard or could clarify. Is this, am I exaggerating the change? I think a lot of this comes from, I would guess in the future that somebody from CTEP attend their session, because oftentimes are concerned more with CTEP than with MU-NCORP leadership, and I've been told that before. So thank you.
So Jeff, I couldn't hear everything that you said because you were breaking up. Let me make sure I understand.
Main concern about DTLs, increasing number and requirements for high numbers of studies. DTL, I understand there's been some policy change or an evolution. Maybe it's just the previous policy and it's now coming to fruit, and we the staff necessarily to be able to do this, and it also impacts on so many different people who we want to participate in studies.
So you're talking about the delegation logs, is that?
Allocation of task logs, so everybody involved in the study has to sign these. Our regulatory people have to go.
I think there are ways, and this would be good, I think, as was brought up earlier, you know, if we can share practices, because I have heard of ways of doing this electronically, and with, you know, electronic signatures, DocuSign, other things where it, you know, it can be done much easier. And I think if we can learn from each other some of these best electronic virtual practices, that might be good.
I understand, but in a community setting, where you have so many different places, different people, it's just very different. It's just very difficult to get anybody to respond, whatever recognize it, but definitely we have this problem. I don't know if Bernard could comment, a change, or is this just an evolution, or how does this play out?
So, yeah, Jeff, thanks for sharing that. Ask you, I guess the response to your question does this mean that there's also a problem in terms of accessible to the technology that's necessary to fulfill these these electronic signatures and things of that nature? Is that a major problem where you are? For accessibility for all
just
involved.
getting people, so every if a trial has to have, every trial has to have 20 people sign, that they've read the delegation law. Just think about the amount of work that's involved. And it's fine when you're only dealing with a few trials and you have, pharma trials, but, if it's going to increase to so many different numbers of trials, it's a huge burden. It's a time burden particularly for the regulatory staff who are in charge of doing this, or whatever staff you have.
And I guess we hadn't from our side, it doesn't appear that we provided some some loopholes, sort of like the informed consent and the CIRB has provided, loopholes and things of that nature, relaxed more of the requirements. Have we not provided relaxation with regards to that? I see Marge Good is on, so.
Yeah, Barn, this is Marge. I unfortunately, this is it's more of a mandate. We're going to put the blame on the FDA because that is where this is mostly coming from. We have to, as the NCI, follow their regulatory indications. And for any study that has an IND involved, there will be a delegation of task log, and that's going to also involve some of our MU-NCORP studies. Particularly, we have a couple of alliance studies that are coming in soon that have INDs associated with devices, and those studies are going to require a delegation of task log. And it could be over time that all of our trials are going to require that. I agree with Dr. Hirschman, and I think that we need to probably share best practices and how some sites are doing this in maybe a more effective and an efficient way. The idea that it can go away and we don't want to do it, or it may disappear if we wish it to, I'm not sure that's reasonable or realistic. I think we're going to have to think about ways that we can somehow make this happen.
Hi, this is Kamara with Upstate Carolina MU-NCORP. I just wanted to add for our site in regards to remote work, we also are running into some challenges, but we've worked on a hybrid approach where we have our regulatory team, for the most part, is working remote, and our staff that are patient facing are required to be here full-time, available in the clinics. We started out maybe the first month when we were looking at, particularly just 1 month, we were considering people working remote full-time for a period. And we were doing a lot of data during that time, but we quickly realized we needed to be here for our patients and to continue accrual. So I understand where you're coming from. It's really hard to continue the communication when you're remote. But in addition, we've been able to add one of our electronic Florence e-regulatory binder system, which has really helped with our auditing. And we're rolling it out. Right now it's with Spartanburg, but we are rolling it out for all of our Upstate Carolina MU-NCORP members. And I think that's, I guess, one of our silver linings that COVID had brought for our group is that we're able to really push that forward, and it will allow remote access for monitors. It allows for delegation logs and training logs, and the staff can just click and sign, and it's a single sign-on. So we're pleased, at least, that that's worked for us. I know that not all systems have that capability or don't have access to that software, but we're very fortunate that we were able to roll that out.
Can you just restate what that software is?
Sure, it's Florence, it's an e-regulatory software, and we've used it for some of our audits with SWOG, and they have, well, at least from what we know, it was very successful. Thank you.
That's very helpful. Thank you.
Don, did you get that name? Was it Florence? Okay, as in Nightingale. All right, got it.
Have any of the sites faced issues with staff and childcare and trying to coordinate all of that? I know we have these issues on every single position, you know, how to sort of manage. I don't know if anybody's, like, I really like the last strategy of people sort of trading off. What if anybody's come up with a strategy for their site in terms of how to deal with some of these issues?
Well, Don, I'll jump in. This is Ray. We experienced that. In fact, it was the child care challenge that actually forced my very conservative healthcare system to actually accept that research staff had to work from home. The initial directive was, no, we don't do this. We don't even give you access remotely to the electronic health record because of all these concerns about, you know, security and being held ransomware and things like that. But it became very evident when children were at home and there was nobody to watch them that you were either going to have to lose your staff if you made them choose between the job and their kids. That's not even a fight. Forget about fair fight. And I think when we heard enough about that, our administration actually changed track. The challenge, of course, is going to be when COVID is deemed to be essentially controlled, policy change, schools versus hospital versus research team may not take the same timeline. So it's going to be interesting to see how we work that out. And if anybody has already worked that out, it would be wonderful to share. Well, I was expecting a torrent of emotion, but looks like SWOG investigators are pretty cool under pressure. All right.
I mean, one of the issues that we've been sort of trying to face is, you know, how can we sort of create like coverage teams, you know, in a better way, both at the physician, nurse, you know, administrator, you know, regulatory, every level is affected by this. And, you know, how can we create backup teams so that there's always coverage, but that people don't feel that intense anxiety, you know, in terms of all the time, what are they going to do?
Don't see anything in the chat room. Don't see anybody holding up their hands. So
this is Scott Delacroix. I had a quick question. When will we expect quote unquote normal site reviews to happen again? Audits.
I'm not sure if they're ever going to go back the way they were. But we can, you know, like, I think that's one of those things like Alan List was bringing up, like how much actually does need to be done in person? How good are these remote audits? What, you know, is there really a difference in quality? How much money do we save by not having to have these things in person? And so I think those are the kinds of things that SWOG ops and stats and data management are looking into.
This is Leslie. Can you hear me?
Yes.
Yeah. So I think Werda is on also, but we're also looking into, I know she was trying to make a comment when Augusto was talking, but she and Meg Mooney and also in our early phase program are looking into what of these changes are not only not detrimental, but maybe beneficial. And, you know, what can we keep permanently? And I'm sure that the audit guidelines would be one of the things on that list, as well as remote consenting and some of the other things that were talked about earlier. So it's actively being worked on.
I mean, one thing, we can reach out to our digital engagement committee, and I brought this up earlier, and would encourage people to share their best practices so that they can create like SOPs for dealing with some of these situations that have worked for some of the sites and contacts, so that, you know, we can all, you know, come up with a little bit more streamlined ways to learn from each other.
Well, I suppose I'll ask a question. In this time of doom and gloom, what is the best thing that has happened in hindsight? Where is the silver lining here?
I'll jump on this. Delacroix from Gulf South MU-NCORP. The silver lining for us was really, you know, we had a certain way that we do it, and every place has a certain way that they do it. And you get sort of trapped into, this is the only way to do it. And this really made us think outside the box. It made us change what we're doing. Some of those things we don't like, but we've adopted, as Augusto was saying before, we've adopted some practices that I think are going to end up being our best practices. But for, you know, this you know, tragic pandemic, I don't think we would have changed some of these things for the better. So and you know, to a point that was stated before about, you know, schools and childcare, that has been our, not just in research, just in the clinics, especially when you have a lot of younger nurses, male and female, with kids. If the schools are closed, it really provides an obstacle to people getting to work, and really it became more than one nurse working with one doctor. You know, people had to learn to cross cover. And just as we all know, if you're in the clinic and your nurse is out, if they have surgery or they're sick, you're like, oh, well, let me push this patient back 2 weeks till my nurse gets back, because you feel like you can't operate except within your own team. And this has really provided everybody an opportunity for growth. And people who didn't understand certain trials, now they understand them all. You can plug one employee in for another, and you're really not losing any steps. So, you know, that's the positive. I'm not a doom and gloom in all this. I think it's made us stronger and better. We're going to come out of this stronger than we were before. So that's it.
Love it. Amen to that. I think that's a perfect note to end this meeting. Just one last announcement. Please remember this part 2 of the MU-NCORP annual meeting is from 2 to 5 p.m. Eastern time on October the 6th. That's Tuesday, October the 6th. And Scott, thank you for that rousing, positive message to end this session. Everyone, please stay safe. And thank you for joining us this evening.
Thank you.
all.
Thank
Bye-bye.
Bye-bye.
Bye.